Hey everybody, welcome to this training on tension pneumothorax management. This is part of the training that we are required from the state to do for our finger thoracostomy or simple thoracostomy procedure waiver, but we're going to put that in the context of what we're trying to managing, which is tension pneumothorax. So we'll get through this. It'll be a little short of an hour, but we'll get through this training, and this will cover part of our 3-hour annual training requirement that we have to do to maintain that waiver. So what we're going to work on today is cover those requirements, and these are what the state specifically asks us to do, which is to go over the anatomy and physiology, talk about the pathophysiology, which is what goes wrong when the patient's injured and sick. We're going to cover the procedure elements that are important, but we'll also have a separate video for finger thoracostomy and needle decompression, showing the steps for that. That'll go along with this. We're going to talk about what to do after we do the procedure if the tension pneumothorax recurs, and then we'll talk about post-procedural care. And we'll throw in a few other things too. This topic is something that I've presented on with some of my colleagues at the national, international level, because there's really been some important movement on this and how we train on it, how it gets applied in the field, and some of the data actually coming out of the bigger organizations like the military are showing that we probably misunderstand tension pneumothorax in some important ways that we want to think about. So first and foremost, let's go through our normal respiratory mechanics. So what we have here is a really simple diagram of the chest. We've got the chest wall on the right and left. We've got some lungs sitting in the middle of it. We have the diaphragm on the bottom. It's a closed system. And if we were to take a pressure gauge and put it in that space right here between the lung and the chest wall, which is called the pleural space, we can measure that pressure there, and we would compare it to the pressure outside in the normal atmosphere. So a couple of assumptions we're going to have here is that the airway and the outside pressure are always basically zero. Because the airway is open to the outside, we're going to assume that it is exactly the same as the outside pressure. And what we'll notice is because the lungs are stretchy and like a rubber band filled with air, they're always trying to collapse. They're always trying to get smaller. And so that means that if we look at the space here, that lung is always trying to pull away from the wall of the chest. And normally there is no space there. Normally that lung is right up against the side. But just for simplicity, to show this in a diagram, we've left a little bit of room. So if we measure that pressure, it is always going to be slightly negative as long as the lungs are inflated. Now, again, if you close your mouth and plug your nose and blow out really hard, obviously there's going to be positive pressure in the inside of the chest and inside of that space. So that's if we're forcefully exhaling. We're just going to assume normal breathing at rest, where the airway is wide open and we're just breathing in and out. So how do we breathe in and out? Generally, we're going to tension the diaphragm here, and because it's a dome, it's going to pull down, making more space in here and making that pressure just a little bit more negative than it was before. And because that pressure is more negative now, we have a little bit of a negative pressure that's pulling air into the airway, and we're going to breathe in. And yeah, the chest wall is going to expand a little bit too if we're using our intercostal muscles, but keeping it simple, we're expanding the size of the inside of the chest, and we are pulling air in. Now, when we breathe out, what happens is that's passive. Because like I said, that lung wants to collapse. It's elastic and it's always pulling in. That when we relax the chest wall and relax the diaphragm muscle, the chest gets smaller and the air passively gets pushed back out again. But that whole time we're in here, this pleural space pressure that we're measuring with just between the lungs and the chest wall is always just a little bit negative, and that's what keeps the lungs stuck to the chest wall, is that negative pressure. Now let's add some complexity here. Actually, each side of the chest is its own compartment. They're sealed off. They don't connect to each other, so we can diagram that. And of course, we're going to need to throw a heart in the middle of this. And that's going to be important later on when we talk about what happens when we end up in tension pneumothorax. So let's go over some definitions here. So just the terminology can be a little bit complicated. These are all, Greek and Latin terms, of course, because we're working in medicine. And what do these things mean? Pneumothorax just simply means there's air in the chest. And specifically, it means there's air in that space between the outside of the lung and the inside lining of the chest wall, where there's normally no space there. They're usually right up against each other. Hemothorax, same deal. We just have bleeding instead of air, so there's blood in the chest. Now, generally for our trauma patients, we're going to have pneumothorax. Usually we're going to have both a little bit of bleeding and usually a lot more air, and all that it means is just blood and air in the chest. The next question we have is this an open pneumothorax or a closed pneumothorax? An open pneumothorax is when we have a hole in the chest wall that's allowing air passage in and out. And versus closed, which would be like a spontaneous pneumothorax, where somebody just has a hole in their lung that's leaking out. Or maybe they have a puncture wound that's too small to actually pass air in and out. That's kind of an open, kind of a closed, but we'll talk about that in a minute. The next question that we have is this a simple pneumothorax or is this a tension pneumothorax? And what that means is the pleural pressure that we're measuring with that little gauge either negative, 0, one or the other, or is it positive? So if it's negative, that's the normal state. If it's 0, that would be if we had an open pneumothorax without tension, and then positive pressure inside that space is going to be our tension pneumothorax, and we'll go through the diagram of that in a minute. The next question we have is it spontaneous versus traumatic? So some people just pop a lung sometimes. Some of our chronic lung patients, especially if they have COPD or other chronic lung issues, even some of the genetic lung issues, they'll have these things called blebs. And they're just basically these things that look like little bubbles, and they're easy to pop. And they can pop, and basically now you have a leak from the inside of the lung into that space around the lung, and that can just leak out. And we'll talk about that too. Now, if I have a simple pneumothorax, which just means that there's some air between the chest wall and the lung, then we can quantify that. And, that can go anywhere from 0 to 100%. So like a 1% or a 10% pneumothorax means that 10% of that space in the pleural space is full of air rather than lung. Whereas 100% means that the lung is completely collapsed and that whole side of the chest is just air. The next term we want to talk about is iatrogenic, and that just basically means the doctor did it, or some medical procedure or something that we're doing medically caused the pneumothorax. That could be, people who have fluid around the lungs drained in an outpatient procedure where they'll put a needle or a catheter in to do that, or central line placement, or any kind of instrumentation around the chest or into the chest. And also what can happen as well is if we have a patient on positive pressure ventilation and that pressure in the chest gets too high, it can pop a pneumothorax. But anytime that has to do with a medical procedure, we call it iatrogenic. So how would we chain these things together? So we could say the patient has a closed, spontaneous, tension pneumothorax. Closed meaning there's no hole in the outside of the chest. Whatever air is leaking is happening inside. Spontaneous means it happened on its own. It wasn't our fault. The patient didn't get stabbed or anything like that. Tension means that there's increased pressure inside the chest, and then obviously pneumothorax means there's just air and no blood. And again, we can mix and match up those terms as we go through. Here's some CT scan examples. So what you're looking at here is you're looking straight towards the patient as though the patient's looking at you. You can see lungs on both sides, trachea in the middle, and on x-rays and CTs, air is black, bone is white, and then soft tissue is gray or somewhere in between the black and the white. And you can see normally here, the lung goes all the way up to the surface of the chest wall. So this pleural space is empty. We call that a potential space. Over here we see on the patient's right side, and again this is flipped but right and left because it's like the patient's looking at you, we can see on the right side this black line that's all the way around the lung. This is a relatively small pneumothorax. This is air, the black that's in here. And you can see on the other side, maybe they're pointing some arrows at a little bit here, but I'm not seeing very much pneumothorax on the other side. So you can have it on one side, you can have it on both sides, but the two don't connect. What we see over here on this picture is the lung is completely collapsed. This is a 100% pneumothorax. We don't see any blood pooling in here. There's no little gray line down here at the bottom. This is just all black and all air. Now, looking at this, it does look like things are starting to push over a little bit to the side, and so this is probably a developing tension, but hard to say without measuring the pressure, looking at what the patient's doing. But if you look in the trachea here, this is an endotracheal tube. This is a patient who is on positive pressure ventilation and intubated, and we're going to talk about how that's a very dangerous setting for pneumothorax, specifically tension pneumothorax. Okay, so let's talk about an open, simple pneumothorax. So what do we mean by that? Again, airway and outside pressure is going to be assumed to be 0. And then the pressure in the pleural space is going to be 0 because with an open simple pneumothorax, we'll say there's a big hole right here that's allowing free passage of air in and out. Now, because the pleural pressure is 0 on that side and because air can flow in, this elastic lung is going to shrink and basically collapse onto itself. It wants to collapse, the way to think about it. So it does. And that's going to cause us a simple pneumothorax. And if this runs long enough, eventually that lung is going to completely collapse all the way. And it's going to look just like this, this pneumothorax that we see on the CT scan over here. Now, if we talk about a closed simple pneumothorax, again, pressure in the airway and pressure outside is 0. What happens is we have a hole in the lung itself, even though the chest wall is intact. So what's happening here is because there's a negative pressure in here, it's going to slowly pull air out of the lungs into this space, and that's going to slowly leak over time. So this would be a spontaneous pneumothorax, or maybe a blunt trauma pneumothorax, maybe a broken rib has poked a hole in the lung, or the patient's popped a bleb. But this is going to be spontaneous, and it's slowly going to leak air, and this lung is slowly going to collapse over time, unless somehow that hole patches itself up, which sometimes, these will heal up, and the patient will get a small pneumothorax that'll stop growing, or sometimes it'll collapse completely, and they'll seek medical care because they feel weird. Okay, so let's talk a little bit about this. So again, ignore that this is probably, in this particular CT scan is probably tension, but I just want to use this for an example. If I have a 100% pneumothorax, but the pressure inside of the chest is 0, it's not positive, it's 0, this is no big deal. People do this all the time. We see this in the emergency room, where they basically pop their lung, either doing things like coughing, breath holding, taking a big pull off a bong, smoking marijuana, and coughing on it. So the positive Valsalva thing can cause an air leak there, or even weird stuff like decompression. People who are doing scuba diving and things like that can get these things spontaneous. So when I say it's no big deal, there's some conditions to that. First off, the other lung has to be okay. Obviously, having both lungs down is bad. You can't exchange air and CO2. You'd suffocate. Also, we're assuming the patient is healthy. The other lung is healthy and fine. You really only need one lung to sustain normal ventilation and oxygenation, but old people who have very poor physiologic reserve, people who are sick, people who have chronic lung disease, or our polytrauma patients who have a bunch of other things going on, they don't handle it well. But if this is a spontaneous pneumothorax in a normal, healthy person, this is no big deal. There's no big emergency to fix here. That's because this pleural pressure isn't positive. But if we have some kind of a one-way valve, either through the chest wall or coming out of the lung here, and if we put the patient on any kind of positive pressure ventilation, that is very bad, because what will happen is this pressure inside the chest will go from 0 to slightly positive, and that's going to cause us a bunch of problems, and let's talk about why. So a tension pneumothorax is when we measure that pressure in the pleural space and it's positive. It's not 0 and it's not negative. But how positive? What kind of pressures are we talking about here? So this is important when we start to think about how the heart works. And the big thing here is the lowest pressure part of the heart that we're worried about is the inferior vena cava, superior vena cava, and the right atrium. And when we look at these, those are going to have exactly the same pressure as our venous pressure. And if we were to measure that like we measure a blood pressure, it'd be about 12 millimeters of mercury, ballpark, goes up and down. But that 12 millimeters of mercury is necessary. That is the preload for the heart. That is the feeding pressure to fill the right atrium so that we can fill the right ventricle. So if that gets too low, the right ventricle can't fill. If it can't fill, it can't pump, which means it can't supply blood through the lungs and over to the left atrium. And then same deal. If the left atrium can't fill, the left ventricle can't fill, it can't pump. This pump vapor locks. So when we block the feed line going into a pump, we get cavitation. The pump stops. You guys understand this when you're thinking about running pumps and moving water around on the fireside of your job. It's exactly the same thing in the heart. So if the pump stops and that pump is the heart, that's basically cardiac arrest. That patient's dead. And it doesn't take much pressure to collapse that inferior vena cava and that right atrium. Let's take a look at this. So summary, and we'll take a look at that, but let's summarize so far. So a simple pneumothorax doesn't increase pressure on the heart and the inferior vena cava, and so it's not a big deal unless it's a bilateral pneumothorax or the patient is otherwise sick. Tension pneumothorax isn't a breathing and ventilation issue. It's a plumbing issue. It is obstructive shock from pressure on the IVC. It's blocking circulation and blocking flow. Remember, pressure is the problem. The lung collapse isn't the problem, and the breathing isn't the problem. It is the pressure that's going to kill the patient. And tension is a plumbing problem, not an HVAC problem. By the way, extra credit if you can name the Robert De Niro movie where he played a commando HVAC hero. It's one of my favorite weird movies. So let's talk about context of tension pneumothorax. Where does this happen? And so we always want to think about this happening in a context because the other things going on with the patient are important. And many of these tension pneumothorax patients we're talking about are going to be in our traumatic patients. So our contact lacks diagnostic certainty. So that's tough because a lot of the people writing the guidelines, building how we do this, they live in the hospital and they live in the operating room. They're ER docs and trauma surgeons where we have all this diagnostic techniques and we're working in a fairly safe, quiet, well-lit room. We have a lot more flexibility. But you guys will have no ultrasound, no x-ray, no CT. It's just physical exam and level of suspicion of what's going on. And it's also, remember, there's all the chaos going on. It can be a loud scene, a dark scene. There can be multiple patients. We can have dangerous scenes. It could be a motor vehicle accident on the highway at night. It could be a mass shooting scene, MCI scene, all these different things. So what I want to do is I want to split this tension pneumothorax into 4 different patient contexts that we would take a look at. And what we're going to think about is first off just a spontaneous pneumothorax that developed tension, which is pretty rare, but it's the simplest case that we can think about. Then we'll talk about positive pressure ventilation. So a patient who has a supraglottic airway, so an iGel or a King LT, and we're bagging the patient or they're on a ventilator. That's going to be a very common and a very quickly developing tension pneumothorax. Then we think about our polytrauma patient who is presenting with tension pneumothorax, and then we're going to talk about a traumatic cardiac arrest. So we go back to our closed pneumothorax. So this is a closed spontaneous pneumothorax. Let's say there's a hole in the lung, it's leaking air out, there's no hole in the chest, the outside of the chest looks just fine, there's nothing for us to patch or cover or anything like that. And we talked about this is no big deal in most of these patients because the lung will slowly drop. It might drop all the way, it might drop most of the way, but as long as there's no increased pressure on the heart, specifically the IVC and the right atrium, this is no big deal. These are, like we said, the COPD patient who popped a bleb. This could be post-medical procedure or iatrogenics or our Valsalva stuff, scuba diving, marijuana, breath holding, things like that. These progress over days. It is simple, so the pressure inside here is low. It is either negative or 0. The patient will have very mild symptoms. They'll feel a little short of breath. Maybe they have dyspnea on exertion. If you look at their vital signs, their heart rate's going to be higher than their baseline, which if you have someone who's like an extreme athlete, they might still be in the normal range, but just running higher than what their normal would be. They may have some mild hypoxia. This is from VQ mismatch, ventilation perfusion mismatch. Because that collapsed lung can't exchange any air, the blood flowing through it's going to pass through, and it's going to still be as the same oxygen status as venous blood. It's really hard, though, to progress to tension because once this lung collapses 100% on this side, the flow of the air stops because you're not really pulling any air through that. You're taking in your breath. It eventually goes to 0 and the flow stops. But there's, something else has to happen to get this into tension. Either they've got to have some positive pressure or some weird physiology, or maybe something weird like they went from sea level to altitude and they had a full complete pneumothorax, but when they come up to Denver altitude or a higher altitude, if you're working up in the mountains, now there is lower pressure outside, so relatively more pressure inside the chest. So what is the treatment for this? A closed pneumothorax is going to be oxygen. We're going to give some intravenous fluids for this patient if their blood pressure is a little low and they'll tachycardic. And what that does is that increases the preload. It increases that venous pressure in the IVC. And we're going to look for other causes for their shortness of breath and mild vital signs. Because again, we don't have the ability to see inside the chest to be sure that's what's happening. We don't want to anchor on pneumothorax causing this problem or developing tension pneumothorax. We want to keep that on our list. We want to look for other things. Is it sepsis? Is it lung disease? Is it an airway issue? Is the patient having something else going on that's making them sick? Make sure that you're not anchoring on pneumothorax as the cause, but you're thinking of all the possibilities, including pneumothorax. Now, let's say we have this patient with respiratory distress and we put them on positive pressure ventilation. That could be CPAP or BiPAP, or we intubate the patient and put them on the ventilator or bag them. That changes the situation dramatically because now we're pushing air into the chest. Now that air leaking out of the lung can form positive pressure in the chest and put pressure on the inferior vena cava and the right atrium. So a patient with a 100% pneumothorax, closed pneumothorax, can be totally fine for days, but as soon as we apply positive pressure ventilation, they can go downhill very fast. And let's talk about why. We're putting pressure into the chest. So that means thinking about how much pressure matters, we want to take a look. So our inferior vena cava pressure is about 12 millimeters of mercury. And when you go and convert that to centimeters of water, which is how we measure airway pressure and ventilation pressure, they're close to each other. They're similar units, but it's about 16 centimeters of water is the venous pressure that we have inside the chest, ballpark. If I put the patient on CPAP, that can create up to 10 centimeters of water pressure going into the chest. And if all I have to work with in my IVC is 16, and that's if the patient's healthy and fully hydrated and not having hypovolemia, I'm taking away like 2/3 of the patient's venous pressure by squeezing the chest with that CPAP. Now, if I put the patient on a bag valve mask, or I have an intubated patient or a supraglottic airway or a surgical airway, our peak pressure is up to 30 centimeters of water, or even higher if we're over bagging the patient. That 30 centimeters of water is almost twice the IVC pressure. So if that pressure is leaking into the chest, we can very quickly exceed the IVC pressure, collapse the IVC on the right side of the heart, vapor lock, cavitate that. The heart is a pump, and the patient will go into cardiac arrest. But this is a slow process. What do they go through? Is they develop the tension, and the early part of the tension, they're just in obstructive shock. So they'll have high heart rate generally, low blood pressure, trouble breathing, and they're going to look shocky and sick. They're going to have end organ perfusion issues, and they're going to feel like they're dying. So that's the thing that we're going to see when we do this. Again, if they're awake enough to tell us about that. Obviously, if we're able to intubate them in the field, they're probably going to have mental status issues and other things going on. So again, what are our signs of tension? Worst dyspnea, because you can't inhale on that tension side. It has positive pressure. You can't generate negative pressure to breathe in. If we're bagging the patient, it's going to be harder to bag because that side of the chest is full. If we look at the chest, we have the patient's chest bare, you'll see unilateral chest rise because the tension side is full. It'll be hyperinflated, and the other side is going to be is only going to be the side that's moving, and the patient's going to be in shock. They're going to have lowering BP and increasing heart rate. And what's our intervention for this? For a spontaneous tension pneumothorax or a patient on positive pressure ventilation who's not a trauma patient, needle decompression is going to be our procedure. Our finger thoracotomy is only for traumatic cardiac arrest or traumatic tension pneumothorax. In peri-arrest, and we'll talk about that, that's a condition of the state waiver that it's only allowable in those settings. So we would use our needle decompression. So let's move to a different patient. Let's think of a trauma patient. So here's the problem. The tension diagnosis in the field requires different criteria. The patient needs to have evidence of shock on our vital signs, has to have shortness of breath or respiratory distress, and there has to be a mechanism that could cause this, and that can be penetrating trauma or blunt trauma. But think about this. Because we can't see in the chest, the most common cause of shock and trauma is hemorrhage. It's bleeding. That's the most common thing for all comers for our patients. So yes, some of those patients may have tension and bleeding. They may have a simple pneumothorax and bleeding, or they may just, the only problem they have is the tension pneumothorax itself. But it's relatively rare. It also tends to be overestimated. And we're seeing some data coming out of the military where they're looking back at the combat deaths in Vietnam, which is the foundational data that they used to build out a lot of the modern TCCC combat casualty care guidelines, which we follow in the civilian side. Those have basically filtered out after the wars in Afghanistan and Iraq because we found some new best practices for trauma management. But the foundational data they looked at was autopsy data on soldiers and Marines who died in Vietnam. And they're thinking that probably they overcalled tension pneumothorax in those autopsy data or looking at x-rays. We'll talk about that a little bit more. And then also we'll frequently see field chest decompressions by EMS, and when they get imaging in the ER, they lack tension pneumothorax or pneumothorax on later imaging. And again, no harm, no foul really here, because we understand that you're working in a limited diagnostic space, but sometimes when we get the definitive imaging later, we find out that tension wasn't actually there. So the TCCC guidelines, which are the military tactical casualty care guidelines, and the TECC guidelines, which is the civilian version of that, those are adjusting, and they're changing in certain ways related to pneumothorax, because the feeling is we're probably overestimating, overcalling them. Let's take a little side trip here into one thing that's changing is prevention. So we think about chest seals as our main prevention for tension pneumothorax. So first off, small holes in the chest are unlikely to move air in either direction. So I'm thinking of a small puncture wound. I'm thinking of a gunshot wound to the chest, where we're talking about, somewhere between, a quarter of an inch for a .22 caliber up to maybe a third of an inch or half an inch for, a larger handgun. This small hole, imagine if you took a piece of meat, if you took a big thick steak and you put a half an inch hole through it pushed a pencil through, and then tried to breathe through that hole, push air in and out, it'd be very hard to move air through that. So generally these small holes don't move air in either direction. But this image is a close range shotgun wound to the chest, and you can see there's a gaping hole. This would be a sucking chest wound. This would be an open pneumothorax. And so that's going to be a very different thing. But here's the deal. Even with those small puncture wounds to the chest, even tiny ones from like shrapnel from blasts that we see overseas, or in the US, frankly, the underlying hole in the lung can still leak just fine, even if no air is moving through the hole in the chest. So anytime you have a hole in the chest, remember there's almost certainly a hole in the lung too, and the hole in the lung is the thing that really is concerning for us. So a hole this size is going to it's going to prevent inhalation on that side, right? I can't generate negative pressure because that chest is open to the air. The lung is going to completely collapse underneath it unless I have positive pressure ventilation. You can kind of see the tape up here. I bet that has something to do with an airway that's been placed in this patient, but who knows? So the patient can't breathe on their own. The lung's going to collapse, but there's no way this patient can get tension pneumothorax. You can't build positive pressure on that side of the chest because it's open to the outside space. Here's another thing too, is if we have a puncture wound to the chest, gunshot wound to the chest, blast, whatever we have, generally it takes about 30 minutes for enough air to leak out of that lung or maybe get sucked into the chest with spontaneous breathing. And again, with spontaneous breathing, not positive pressure, it can take up to 30 minutes or more for the tension pneumothorax to develop. So in our general trauma care that we have in our catchment area, that patient is already going to be in the ER before the tension's likely to really be there, or it might be developing at the very end of our when we're caring for the patient. But it's generally not going to be something that we're going to see on arrival, except for some special cases we'll talk about, and it's generally not something that we're going to see developing very quickly unless the patient is on positive pressure ventilation. So we have some time on these things. Again, unless it's an entrapment or a delayed presentation or hostage situation where the patient was shot and we couldn't get to them, or a mass casualty. So again, the weird settings, but our normal, bread and butter trauma patients, we're going to see these very rarely because they take time to develop, and we're pretty fast at getting these people packaged up and moved to the hospital. So we'll talk about chest seals. So chest seals are poorly effective for preventing tension pneumothorax for a couple of reasons. First off, it's probably rarer than we think it is. Also, the smaller puncture wounds probably don't matter. They don't move any air. We cover them up anyway, right? It's not going to cause any problems. There's no air moving in or out. But a big wound doesn't allow pressure to build up. And so that causes some problems, because if we have a large wound like we saw in the patient in the picture and we put a seal over that, now that is sealed, that patient can develop a tension pneumothorax. Now the hyphen that we carry, these hyphen chest seals, they're called vented chest seals. So the adhesive has spaces in these 3 different tracts that allows air, if there's positive pressure, to leak out, but when the patient pulls a negative breath, it won't let air to leak in. But as you can see from these little tracks, they're not super efficient, right? Like they could get clogged, they're stuck to the skin. So you can build up a little bit of pressure in here even with a vented chest seal. And we talked about you don't need very much pressure to get that tension physiology. So if I take an open pneumothorax and I put this on, this allows the patient to then breathe spontaneously. So they're useful for large sucking chest wounds where the patient is breathing spontaneously, because now that patient can pull a negative pressure. But anytime we place this over a wound, we've now increased the likelihood that they develop tension because they're excellent at trapping air inside the chest. So again, no free lunch here. They're useful, but they have some limitations we need to be aware of. Also, if we're thinking about this tension pneumothorax taking 30 minutes or so to become a problem, our initial trauma care, the chest seal isn't the first thing that we're reaching for. We have other priorities that we need to do before we get to the chest seal. Not saying that we're not going to place them, but we need to get other things done before we do that, or we need to task that out to somebody else while we focus on the higher value interventions. So what are our chest seal guidelines? Hemorrhage control, airway, resuscitation, and then patient movement towards the OR come first. Those are the things that are going to get your patient back home again if they have a severe traumatic injury. Chest seals are unnecessary and potentially harmful on patients getting positive pressure ventilation via endotracheal tube or a supraglottic airway. Bag valve mask is a little bit different because we don't have a definitive seal of that airway, and so they're more somewhere in between positive pressure and a spontaneously breathing patient. But if we have a tube in that patient's mouth, a surgical airway, then the chest seals should be open to allow air to leak out, so that we're not setting them up for a pneumo. So if the patient has a sucking chest wound, breathing spontaneously, we do cover the smaller wounds anyway, but we definitely want to cover the sucking chest wounds. But again, make sure that you're covering these higher value, more important things first. Obviously, we usually have lots of hands on scene, so there's people we can task that out. But if you're the primary medic managing this patient, you need to work through your priorities first before you get to that. And then remember, when we see a trauma patient and they're decompensating, they're going into shock, we want to remember it is most likely from hemorrhage, not tension pneumothorax. We want to cover our bases and treat that hemorrhage, a hemorrhagic shock, first while we're either while we're or before we get to the needle decompression and managing a possible tension. So if we look at this, TCCC, which again is the guidelines and standards and training for military combat trauma, they presented in the last two SOMA meetings that we went to that says that they're changing their March algorithm. So March is just it's a slightly different version of X, A, B, C, D, E. We've talked about that in our training too. And so what they're changing is R to resuscitation and not respiration. So if we look at the MARC, which are going to be really the highest priority things, the very first thing and highest priority thing that we're going to work on is control external massive hemorrhage. We're going to do that direct pressure, wound packing, or a tourniquet, depending on where that wound is. That is our highest priority, getting that sorted out, because if the patient bleeds out while we're looking for a needle to decompress the chest, we're not doing the patient any favors. We want to make sure the patient has an airway via the least invasive means possible. So we're going to start with recovery position, jaw tilt, jaw lift, jaw thrust, or a chin lift, depending on our cervical spine concerns. We're going to think about oral airways, supraglottics, endotracheal intubation, and if all else fails and we can't oxygenate or ventilate, surgical airway. But we're going to progress through that and make sure we get the airway with the least means possible. And then R has changed from respiration to begin resuscitation. Ideally with blood. We're going to talk more about a blood waiver and how we're going to get blood to our patients. If we don't have access to blood or it's too far away, we're going to use crystalloid, which is lactated ringers, or for us, normal saline. And our goal is to keep that systolic blood pressure above 90. We're treating the hemorrhagic shock. And then the C is to support circulation. So if we have external hemorrhage under control, we have a good airway, we're beginning our resuscitation, and the patient is in shock and we think they might have tension, this is where we start to think about reversing that tension pneumothorax, because what causes that obstructive shock, where we'd be doing either needle decompression or finger thoracostomy if the patient is peri-arrest or in cardiac arrest. But our biggest priority always is movement towards the operating room is what's going to solve the patient's problem, what's going to get the patient back home again. All of these MARCH or ABC interventions that we talk about, we call these bridging interventions or life-saving interventions. What they're doing is they're keeping the patient alive long enough that we can successfully get them to the operating room. but they don't save the patient all by themselves. They are giving us time to get the patient to definitive care, so always that movement priority needs to be there. And generally, we're going to on scene handle our massive hemorrhage in our airway, and then during transport or maybe partially getting started on scene, getting that resuscitation and circulation support, tension pneumothorax. So our big priority is M and A and move, and then these other things are going to happen either if we have the ability on scene without delaying transport or in the rig as we're moving. So if your patient is in shock, start blood or fluids to correct the hypovolemia before placing chest seals or decompressing the chest. And so, this is going to be our priority for our shocky patients. Now let's move on to our even sicker patients. These are our patients in traumatic arrest or peri-arrest, which is kind of a gray zone of mostly dead. And so if we think about traumatic cardiac arrest, it has very low survival, but it's gray again, right? We work in a realm of diagnostic uncertainty. And so our traumatic arrest definition in the field in EMS is can you or can you not feel a pulse with your finger under stress? We know that in stressful environments or cold environments or really stimulus loaded environments, loud environments, your fine motor skills and your fine sensation deteriorates, so it can be harder to feel a pulse. Also, some of our patients on a normal Tuesday, we have trouble feeling their pulses. That doesn't change when they're injured. So when we think about our algorithms that are built to reverse or treat traumatic cardiac arrest in the field, they're based on patients who I would say, only mostly dead if we're using our Princess Bride reference. And what that really means is they're in profound hypotension, but still have some cardiac activity, but not enough for us to feel a pulse with our fingers. So what are our options there? We've got a couple of high-value things that are fast. So we have our chest decompression to reverse our obstructive shock, and this is where our finger thoracotomy is fast and definitive. In our cardiac arrest, our traumatic arrest, or our peri-arrest patients, we can do that very quickly, and we can vent both sides of the chest. Now, some patients are in traumatic cardiac arrest because of traumatic asphyxia. They couldn't breathe for a certain period of time, and so their heart is anoxic and acidotic, and it's not beating really well. They might need some breaths, so we do our OPA, BVM, or drop an I-gel really quickly and give them some breaths. We want to think about our blood or saline resuscitation, depending on what we have, giving that patient some volume back because hemorrhagic shock is that most common cause. So we'll give some back. And then remember, epinephrine has no role in trauma patients. It doesn't increase survival. It actually worsens survival. Yeah, it'll make their numbers better when you're looking at them, but those numbers aren't the same as surviving. So volume is what fixes trauma. So those are some very fast things, and we're going to talk about, later on in future trainings, we're going to revise our traumatic cardiac arrest protocol to accommodate some of these new things in the Waivered Act. So our blood protocol and our finger thoracostomy protocol. So more to come on that. But those are those things that are going to reverse that hypovolemic shock, asphyxiation, or obstructive shock that might be able to get us vital signs back and get this patient to survive to the OR. Now, use your other tools. Right? So don't focus on exclusively using that the pulses under stress. If there's a possibility the patient still has cardiac activity, can you see pulse ox waveform we put the monitor on? Because maybe that pulse ox can see that pulsatile flow through the capillary beds that we can't feel with our fingers. And also, if we put the cardiac monitor on and we have a narrow complex QRS above 40 per minute, that suggests there's some cardiac activity going on there. Again, pulseless electrical activity is determined on whether or not we can feel a pulse. Maybe it is just profound hypotension and not actually cardiac standstill. So those are all the things that can help us out in our traumatic cardiac arrest patient. Now let's specifically go through the protocol itself and see what we have. So we have our simple finger thoracostomy protocol, and we go through the agency-specific guidelines on this. So first off, the patient must meet all three of the following criteria. This is a very restrictive protocol. So our needle decompression is still going to be our mainstay. This is for a very specific patient population. So first off, an adult patient, and I want you to look at this. It's 13 years and older. That's different from the Denver Metro definition of adult. The state guidelines are using the old 13-year-old and over rather than our Denver Metro age cutoff. The patient needs to be in cardiac arrest, meaning I can't feel a pulse, or peri-arrest due to traumatic injury. So the patient is either in arrest, looks like they're about to arrest, and the cause is trauma. So this isn't for a spontaneous tension pneumothorax. There has to be some clinical concern for tension pneumothorax or tension hemothorax, meaning a traumatic mechanism, something that we saw, leading up to this, penetrating wound to the chest, blunt trauma, etc. What are contraindications? If we have no suspicion for chest trauma, pneumothorax, or hemothorax. So this isn't for just our, a patient with, say, let's say we have a patient who is, had an amputation of their leg and bled out from that. We aren't going to do a finger thoracostomy on them if they're in arrest because they bled out from their hemorrhage, not from an interthoracic problem. If we look at the technique, we're going to put the patient on their back. We're going to have the shoulder flexed, arm rotated and held out of the way as shown below. And we're going to identify that site. And again, we have a video that goes over this, but what is our general thing? We're trying to get into this triangle of safety here, which is above the diaphragm. And remember, the diaphragm sits at rest in our patients at about the nipple line. And so we want to stay to the head, say north of the nipple line. We're going to stay in front of the latissimus dorsi and behind the pectoralis. And we can use the patient's size hand in here to find that space. We can use the little guides that we have. You can follow that that fifth intercostal space up and around to where we're going to go. All of those are going to get you to the same spot, and you should do all of them. And that's, in most patients, you're actually going to be able to feel the chest wall pretty well there. Even obese patients don't have very much fatty tissue in that space, and and even a big muscular patient, that's going to be there's no muscles over that. That's going to be very close to the ribs in the chest wall. Now, we have the provided skin sanitizer. If able, use that to clean off the patient, but speed is going to be the thing here. Obviously, if there's dirt and obvious contamination, clean that off. We don't want that inside the chest. But basically, this is a clean procedure, not a sterile procedure. We're going to create about a 2-inch incision over the 6th rib, which is going to be the rib below the space that we want to go into, because we're going to go up and above, and we're going to cut down to that rib, using that rib as a backstop. We don't want to send the scalpel between the ribs, because it's going to lacerate things that are underneath, as we've seen in our cadaver trainings. And we're going to cut all the way down to make sure that we're through all those little soft tissue membranes until we can feel that we're right on that rib. Any of those little membranes are going to get in the way. If you get to that rib and you find a palpable rib fracture, move out of the way of that, because you don't want to push your finger over a rib fracture. It's a sharp bone edge. It's going to cut your finger and injure you. So you can move up a space, down a space, a little bit anterior, a little bit posterior, whatever makes sense with that patient to get away from that broken rib. We're going to use a sweeping muscle to push through and separate that intercostal muscle from the top of the 5th rib. We're going to push up and over into the thoracic cavity, and you should feel a palpable pop when you enter this pleural space. Remember, there's that membrane lining the inside. There's the parietal pleura lining the inside of the ribs. We need to push through that too, not just between the muscle, but all the way through. And then we're going to move our finger around a sweeping motion inside the thorax to make sure that the pleural space has been entered and any air or blood can be evacuated. Be careful, or you can even skip that sweep if you're really worried that you're going to have sharp edges or rib fractures in there. And you may feel the lung, you feel the heart, but if you're feeling other organs through the 5th intercostal space, avoid other invasive procedures on the side of the chest. You can have a ruptured diaphragm and have stomach and intestines up inside the chest. And if we needle that side of the chest or do other invasive procedures, we can lacerate that and cause more problems. After the procedure's done, we're going to only cover that incision with a vented chest seal if the patient's breathing spontaneously. If the patient's being ventilated by positive pressure ventilation with a supraglottic airway, endotracheal intubation, or surgical airway, we're going to leave that wound open because we want that air to be able to escape so they don't develop a recurrent tension pneumothorax. So it depends what the patient's doing. If we vent the chest and they start breathing spontaneously, they need to have that chest seal in order to generate negative pressure again. And again, once that chest seal's on, they may recollect our tension pneumothorax and we need to burp it. So what are our precautions as we go through here? So we want to make sure that we're going to the chest cavity and not too shallow, and we're in the subcutaneous layer. We also don't want to make sure that we're too deeply and we're perforating the lung. Don't go too low, so too far towards the patient's feet, because you're going to get into the spleen, diaphragm, or liver. The diaphragm sits higher than you think it does. Pleural penetration needs to occur above the rib to decrease the risk of nerve and vascular damage. Remember, those nerves and veins run underneath the rib, so we're going up and over. We want to make sure that we're avoiding injury to intraabdominal organs, which sit surprisingly high in the torso. So again, stay high, stay above the nipple line. Be very cautious perform the finger sweep in patient with suspected rib fractures. We talked about that because we don't want to get you guys hurt while you're taking care of people. And if it looks like the patient's getting recurrent tension physiology, reassess the site and verify pacing with a repeat finger sweep. If there's a chest seal on it, take that seal off, open it up, burp it. But also remember, if the patient is deteriorating and they're a trauma patient, don't forget, hemorrhage is still our highest cause. Make sure that we're adequately resuscitating the patient because they need that volume as well. So we're both going to be thinking about the tension pneumothorax and managing that, but we have to do our fluid resuscitation or our blood resuscitation as well. They go hand in hand. Okay, after the procedure, we need to make sure that we're monitoring cardiac, blood pressure, respiratory rate, saturation, and tidal CO2. All of those need to be done as soon as clinically feasible. If you can't get to one for some reason, document why you couldn't. Just document that, hey, we got all these other things done, but our hands were full. We didn't get around X, Y, or Z. But these should be pretty straightforward. We have enough hands on scene that we should be able to do this. So what are the required documentation? We need justification for the procedure. Just document the patient was in arrest or peri-arrest due to a traumatic injury and your clinical concern for tension pneumothorax or tension hemothorax. Write down what you saw that made you think that. We also need to have a pre- and post-procedure patient assessment. That's true for any of our procedures. Did it work? Did it help? Did it make things worse? Monitor data for the requirements noted above, and that those must be uploaded and part of the chart so that when it gets pulled by the state, which they pull all of our waiver charts, that comes across. They can't really interpret the narrative. It needs to be in the vital signs section of the chart. Also, make sure the EMS division and EMS leadership are notified of any attempted thoracostomy as soon as possible, and it must be notified within 24 hours because we have a time requirement of 1 business day to look at these charts and make sure that we hit all the wickets. Make sure that the EMS division is looking at the chart so that we have all these data points in it before it gets finalized, so we're not going back and opening up the chart and having to add stuff or edit stuff. Make sure that we take a look at that and everything is in there. And that's our finger thoracostomy or simple thoracostomy wayward procedure. So a couple more quick things. I want to go over some tension pneumothorax myth versus reality. This is stuff that we presented on, at some of these big conferences where we're teaching people how to do training on this because we do a ton of training, both for you guys, for the federal stuff that I'm working on, and in a bunch of other settings. So what is the first myth? This is a big thing. Tension pneumothorax happens right after injury. That's something a lot of people believe because of training scar, and it's from poorly designed scenarios where you have a patient with some kind of chest trauma, and the minute the medic comes up, it's assumed that you need to identify and treat tension pneumothorax. And that's not how actual tension pneumothorax develops, especially in a spontaneously breathing patient initially. It can develop very quickly with positive pressure. In an intubated patient, that's a different scenario. So we need to design our training scenarios so that we're coming upon this patient later. They had a delayed presentation. They were in some technical rescue issue, some extrication issue, a hostage situation, where 30 minutes has elapsed since injury and they have that. But this usually happens and takes some time. And we got to remember, what are our exceptions? So positive pressure ventilation, especially intubated patients, and manual bag valve ventilation where the pressures are very high compared to if we have patients on a ventilator where the pressure is regulated. Weird things where there's pressure injected into the chest. So a contact gunshot wound, that the burning gunpowder gases can be basically forced into the chest and cause an instant tension pneumothorax because you're basically inflating the chest with the burning powder gas that's coming out of the gun barrel. Weird industrial accidents with compressed air, certainly can inject stuff in. That'd be unusual. Some of our blast patients, some strange things can happen where they get pressure in the chest. And then some weird pressure issues, like you have a patient scuba diving or an aircraft depressurizes suddenly, or a patient comes up to altitude. I mean, that doesn't really happen very quickly, but there's some weird situations that come in. But generally, a patient who's shot or stabbed or a blunt trauma to the chest that are breathing on their own, it's going to take some time to develop tension pneumothorax. Here's another training scar that we have. Tension pneumothorax is common, and it's common because we have to train on it. So everyone has seen a scenario in training, or multiple scenarios in training, where the patient has tension pneumothorax. And it's probably based on some bad data. So researchers, like I said, they're reevaluating the Vietnam data. That showed 3 to 4% of combat deaths involved tension pneumothorax. But they're looking at patients, days or weeks after the fact on autopsy or looking at x-rays and saying, yeah, that looks like it might be tension. And the thought now is it might be overestimated because the GWAT casualties of patients who were treated in Iraq and Afghanistan over the last 20 some years, they had a lower rate than expected based on the Vietnam data. So it's probably less likely. And then in civilian trauma, it's different. So we have less blasts, we have less penetrating wounds. Our penetrating wounds are different. They tend to be stabs and handgun wounds rather than rifle and shrapnel wounds. We have a lot more blunt trauma than the military does, which has more penetrating trauma. So our civilian patients are less likely to develop these things, even more so than that. So this is relatively rare. Not saying it doesn't exist. We need to look for it. We need to be aware of it. But it's more of a zebra than a horse. Here's another myth. Trauma patient with dyspnea and shock probably has tension pneumothorax. But when we look at PHTLS training and the guidelines and all this stuff, this is a training scar too. Lots of things cause dyspnea and trauma. Airway issues, pulmonary contusion, chest wall injuries. Just a simple pneumothorax will make someone be short of breath. But the most common cause of shock and trauma is bleeding. We need to be addressing that as our primary, and then secondarily thinking about obstructive shock from tension pneumothorax. Here's another one that we see. Needle decompression will reinflate a lung. So if we think back to our pictures that we had there, if we have 100% pneumothorax and we have zero pressure inside of the chest or positive pressure inside the chest, all that this needle is going to do is equalize pressure. It's not going to be able to move the 2,000 milliliters or more of air needed to reinflate the lung. We have to get all that air out of the chest to get the lung, because these things generally get clogged with a little bit blood clots or tissue or fluid, or they tend to get kinked a little bit from the tissue moving in the patient. And remember, we need negative pressure on the catheter or positive pressure in the chest to move any air out of the chest through the needle. But relief of that pressure corrects the obstructive shock. So these are very effective if they're functional and patent, and we talk about in the procedure video how to make sure that catheter is open and not clogged. They will equilibrate the pressure very quickly, but they won't move large volumes of air out to reinflate the lung. But that's not what the patient needs. They need the pressure relieved. They need the obstructive shock relieved. So I think we covered our goals for today. We got our state requirements done for the finger thoracostomy. We have the procedure videos separate from this that go over stepwise how the procedure is to be done. We covered all the different components of the waiver, and that gets us to the end of our credentialing and certification for doing our finger thoracostomy. And also, I think we have a better understanding of tension pneumothorax management. So take a look at those videos. Make sure that you're doing the hands-on training as well with different training models that we have. We'll be revisiting this every time we do cadaver training because it's an important part of that. And keep up all the good work. Thank you very much.